patients with TIA and minor ischemic stroke are at very high risk of subsequent stroke or death. And up until now, the treatment recommended was aspirin, until recently when we had 2 trials showing that dual therapy combining aspirin and ticagrelor was superior to aspirin in 2 trials, one in China, performed in China, one other performed in North America and a little bit in Europe. Leading the American Heart, American Stroke Association to recommend in patients with minor stroke or TIA to prescribe immediately clopidogrel plus aspirin for 21 days as the new gold standard treatment. We decided to test a new P2-112 inhibitor called Ticagrelor, which is well known by cardiologists. Ticagrelor has an advantage on clopidogrel because it is not a prodrug, it is directly acting, and it has a higher platelet inhibition and a more sustained platelet inhibition, a faster onset, quicker offset. And also we have an antidote now, which is in phase 2 and fast track approval by FDA. So with this background, we designed the THALES trial. THALES trial was the randomization of patients with minor stroke or high-risk TIA to either ticagrelor added to aspirin versus aspirin alone plus placebo, with a loading dose of ticagrelor of 180 milligrams the first day, followed by 90 milligram BID for the rest of the 30 days, and a loading dose of aspirin, 300 milligram, followed by 100 milligram the rest of the 90 days. The endpoint was stroke or death, and it was judged at 30 days. So the key results is that ticagrelor added to aspirin found a significant 17% relative risk reduction as compared to aspirin alone. And that there was also an increased risk of major bleeding, ratio of a minimal absolute risk of major bleeding, 0.5% in the ticagrelor plus aspirin arm versus 0.1% in the aspirin arm. An absolute risk that did not outweigh the benefit observed on stroke or death. Then we decided to evaluate the efficacy of ticagrelor plus aspirin in the subgroup of patients with an ipsilateral stenosis at randomization. Ipsilateral stenosis meaning that an atherosclerotic stenosis likely causal of their stroke. And we found that about 2,500 patients had this an ipsilateral stenosis versus 8,600 patients without ipsilateral stenosis. And in the group with ipsilateral stenosis, we found that the beneficial effect was much higher, since the risk on aspirin was 10.9%, and it was 7.9% on ticagrelor plus aspirin, so a 3% absolute risk reduction, a 27% relative risk reduction, a number needed to treat of 34. While in patients without ipsilateral stenosis, there was a 17% relative risk reduction, which was not reaching statistical significance. But probably because of power, lack of power, we did not find a treatment by subgroup ipsilateral stenosis interaction. We just missed statistical significance. But the effect we observed in the group with ipsilateral stenosis was really meaningful, with this number needed to treat of 34 and a number needed to arm of 960, around 960 number needed to arm. So the beneficial risk ratio in the group with ipsilateral stenosis is maximal, and the risk is really minimal in this group. In fact, we had 4 major bleeding in the group with ticagrelor plus aspirin versus 3 in the group on aspirin alone in patients with ipsilateral stenosis. The conclusion is that ticagrelor plus aspirin is superior to aspirin in patients with high-risk TIA or minor ischemic stroke, and that it is also true for a significant reduction of disabling stroke with ticagrelor plus aspirin compared to aspirin alone, which is really something new. And in the subgroup of patients with ipsilateral stenosis, we had an even better reduction with a 3% absolute risk reduction, a very meaningful number needed to treat of 34 and number needed to arm of 960. Which shows that the group with ipsilateral stenosis is really the group to target with ticagrelor plus aspirin, but without heterogeneity in the treatment by subgroup interaction. We cannot say that the patient without ipsilateral stenosis do not benefit from ticagrelor plus aspirin. First, we have to note that the FDA just 3 days ago gave the approval of ticagrelor plus aspirin over aspirin, based on the THALES trial results, to reduce disabling stroke or death in patients with high-risk TIA or minor ischemic stroke. So the next step is really to have the EMA approval also, and the Chinese FDA approval, and also to have it implemented in guidelines as it was for clopidogrel plus aspirin. Now the doctors, the vascular neurologists who will be able to prescribe ticagrelor plus aspirin or clopidogrel plus aspirin in their patient will have to think about which treatment will be better for their patients. And we don't have yet a head-to-head comparison, but based on the fact that clopidogrel is ineffective in 20 to 40% of patients because they have a loss of function allele, CYP2C19, I think that ticagrelor plus aspirin, which is efficacious in 100% on platelet reactivity, platelet blockage. I think that it is more reassuring for the prescriber to prescribe ticagrelor plus aspirin. We will see how the uptake will be, because there are question of cost also. And so it is important to balance all these parameters for the given doctor to prescribe Ticagrelor plus aspirin in that patient with acute minor ischemic stroke or high-risk TIA.